So for the next part of the session, what we're going to do is talk about the patients that you all have seen in your practices and that you were supposed to impanel. Remember that the key things that we wanted, the types of patients that we wanted you to be able to see were patients with back pain or patients with nicotine addiction, so that we could sort of relate those to the case we just heard about. You know, Priya presented the case of Clarence Thomas, and I think Braxton talked about the basic science that surrounded back pain and how to manage back pain. And then Mike talked a little bit about nicotine addiction and the behavioral science aspects of that. And so what we would like to do now is to talk about the patients that you saw in clinic and really sort of relate those to our model case, which is Clarence Thomas, and how we manage Clarence Thomas's back pain. So just who of you were able to impanel a patient with back pain in your practices? Oh, okay, so a good number of you. So Mike, let's start with you. Can you tell me a little bit about the patient that you saw in clinic?
Yeah, she was, I think, a 48-year-old woman. She was doing some heavy lifting, moving, and she suddenly had acute onset of back pain, and she was worried about it. And so she was tender on palpation in the peristernal kind of area muscles. All other signs seemed normal. Reflexes were normal, no loss of sensation. Physical exam there was nothing pertinent in there. And she was worried about workers' comp, so we had to figure out the paperwork and things like that for workers' comp, but it seemed like a muscle strain kind of thing.
Okay, who else had a back pain case that they could talk about? Brad?
I was at a clinic and we had a 14-year-old girl come in who was a gymnast, and she developed an acute episode of back pain while doing a backflip during practice. And her x-rays were normal, but they did a bone scan and they found bilateral spondylolisthesis, I think this was called, at her L5 level. And so they just managed her with some lumbar support and some flexion stretching, and she was restricted to from her gymnastics practice for 3 months. So that was what the doctor...
So interesting case. So she was 16 years old?
14.
14 years old. So spondylolisthesis, does everyone understand what that is? So that's slippage, right? So slippage of the vertebral bodies. Actually, so what happens is the pedicles actually get fractures in them, and then the body moves anteriorly typically. And so what you have is you have a distraction of the two, and depending on the percentage of distraction can depend on what type of treatment needed to be done. So it sounds like in this particular case, the treatment was restriction of activity. So, so how did she take that as a 16-year-old gymnast being told that she couldn't do gymnastics?
Obviously, she was pretty upset about it, especially since she was really involved with her gymnastics, and it was something that she was really passionate about. So she was pretty upset about it. But just tried to talk to her about how eventually down the road, if she took it easy now, that she would be able to recover and hopefully be able to get back to gymnastics. And so once she realized that it would help her long term, I think she was more likely to adhere to our recommendations and stuff. So, but it was definitely upsetting to her at first, and took some talking to her to have her understand that.
Questions?
I was just curious how it all worked with her parents, because I would imagine that was probably difficult for them too, because a teenager who's pretty invested in something like gymnastics, the parents get pretty involved too. So how that interaction worked?
I think both the parents. Sorry, I guess both the parents came in, and mom was like trying to see if she could get back, like trying to see when was the soonest she could get back to training and stuff, and dad was more like reasonable and understood the severity of the injury, and kind of was like, we need to look at this for long term, kind of down the road. We want her to be able to have a healthy back when she's a adult and stuff. So it was kind of just like managing all different three people was interesting, but the doctor did a good job of getting everyone's sort of opinion and was able to mediate the situation and stuff.
How soon after were you going to see her back again? Because, so teenagers can sort of have some difficulty with compliance, especially if there's peer pressure. Were you going to see her back more frequently than in 3
Yeah,
months?
she was restricted to 3 months of not doing gymnastics, but the doctor wanted to see her back in 2 weeks just to make sure that the pain wasn't getting any worse or anything, and that it was getting better and not going the other direction. So.
Ellis, did you have a question?
I was just surprised that there wasn't any, at least I didn't pick up on any medications that she was given for pain. I mean, it sounds like that could be an extremely painful problem in the acute setting, and I was wondering about pain management.
Yeah, the attending doctor didn't really talk much about that, but he was more aligned with doing like stretches and stuff like that, and just restricting the her gymnastics. He thought that was just be the best way to manage it. I think he said if the pain got really intense, she could take some sort of anti-inflammatory like ibuprofen or something like that. But he said try to just manage it with stretching and restriction of activity. For the most part.
That's what's interesting about spondylolisthesis is it hurts as soon as it happens, and it hurts for a few days after, but then the pain is typically with a certain types of motion. So with hyperextension or with hyperextension type activities, that's when it aggravates. So if you limit, or even sometimes bracing, can simply relieve the pain because you're not sort of causing further distraction there. Okay, interesting. Other back pain case that we had in clinic?
So I had a 44-year-old white male who presented I was volunteering at the Physicians Free Clinic at the time, and he was presented with acute back pain, mainly from lifting furniture. So we did a bunch of physical exams. He was pretty tender in the area of his lower back. He had some sensory deficits along his left, L5 dermatome. But he didn't have any loss of, muscle strength and no loss of reflexes or anything like that. So we ended up not doing any radiological exams on him, sent him home with just NSAIDs and just a sheet for some back exercises for him to do.
So this is a patient with a neurologic finding, right? So they had sensory abnormalities, and you said an L5 distribution.
That's right.
Questions?
So, I guess with back pain, it seems like a lot of times you either send the patient back with no medication or just something they could basically get over the counter. So how do you deal with like the patient's frustration? Like, do they have frustration when they come in and they have these problems, and then you just, are saying like, basically take an Advil for it? Like, how does that happen? How does that interaction
Yeah,
happen?
I think, being 44, he had like a pretty big family, and he was kind of worried about being able to get back to work and everything like that. So he was definitely on the more frustrated side. But I think in terms of his long-term health, having him, rest and just have the inflammation, reduce in its regular course would have helped him long-term.
So like in the Clarence Thomas case, remember what we talked about was the frequent checks, so frequent neurochecks to sort of monitor the patient. So in this particular case, when you have someone who does have a neurologic deficit, and I know you're in the free clinic setting where you don't like to see patients back on a regular basis, did you sort of establish like when the patient should like come back or come to the emergency department urgently if certain things would develop?
Yeah, we had originally scheduled him for just a 2-week follow-up,
Okay.
but we let him know that, if there were any alarm signs that arose, like any further development of sensory deficits through other dermatomes or development of muscle weakness or loss of reflexes or anything like that, that he should probably seek pretty emergent medical care.
So like what Mike in the presentation talked about, the alarm symptoms that you need to do for patients with back pain and neurologic deficit. So you sort of explain those to the patient when they should. Okay, great.
A quick question. You might have briefly touched on this, but if you did have some neurological signs, one would be, I guess, how many alarm systems would you reach before you do imaging and things like that?
I think since the pain was acute and it didn't seem like it was particularly severe, while the sensory deficits are, alarming, I thought we kind of just wanted to see how it play out once we gave him anti-inflammatories, hoping that maybe like an impinged nerve or something like that would become less impinged once the inflammation kind of died down.
Remember, it goes back to what we said in the presentation was progression of symptoms. So as long as the patient understands, so now if you develop weakness or difficulty with walking, or if that numbness changes and coming over a bigger area, if you develop any bowel or bladder changes, then these are a further progression, and we need to see you right away, or if we're not here, you need to be able to go to the emergency department, because that means there's a progression of whatever that problem might be.
Ed, was the patient aware of the sensory deficits? Like, obviously knew they were in pain, but did they know, like, or did you just find that on your testing of the dermatomes?
I don't think he knew because it was, kind of just lower leg on the outside. So I don't think he detected. He was more concerned with his, back pain and all that. So.
Interesting. So you had to do some patient education in that arena as well. Okay. Another back pain case? Sean, yeah.
Yeah, I was in my preceptorship, and this one patient showed up who is a 22-year-old male, and he said he had 10 out of 10 back pain. And doing the physical exam, he had very exaggerated reflexes on the exam, and he really didn't have any focal neurological deficits that we could tell, but we still prescribed him Tylenol. But then the office later got a call from the pharmacy saying that the patient had tried to fill multiple prescriptions for painkillers from different physicians. And so it was most likely, I guess, feigning 10 out of 10 back pain. So that was interesting to actually see that seeing the patient, how they presented that as well. So. We did not see the patient again, actually. Yeah, because we initially told them to, if you're still having problems, contact us, and never heard from them again. So I guess the pharmacy just probably caught on to, they found out that the pharmacy found out, I guess they decided not to. I shouldn't conjecture, but that is my guess of what happened, I guess.
So sometimes we feel a little bit more comfortable with objective signs and symptoms, right? Things that you can actually reproduce on a physical exam versus subjective, which pain is subjective, right? So even tenderness is a subjective, right? So by me palpating a muscle and someone says, ouch, that hurts, that's not objective, that's subjective. And so sometimes if there are no corroborating objective findings, that you're in that quandary is this person in 10 out of 10 pain and still being able to sit there in the office and talk to me about their 10 out of 10 pain, and sort of the things that you need to think about as well that potentially could be contributing to what this patient wants. I just find it interesting that sometimes the easiest thing is to prescribe so that the patient sort of moves on, but that's not always the best thing, right, for the patient. And obviously an astute pharmacist caught that and was able to say, this person has other narcotic prescriptions, and you're right, that sort of sets the difficulty that's there. I think, though, what do people think about a follow-up conversation with that patient?
I think that's a good idea if you can get him back in. I mean, if he realizes you're not going to give him, because you said you prescribed him Tylenol, so yeah, it's probably not the drug he wanted. So try to get him back to the office would be probably difficult, but if you could get him back in, then he needs to have some sort of intervention. But
Sure.
I just wonder if looking back on it now, when you relive that sort of patient encounter, if you think of maybe he had habits about him or a mannerism that was indicative of a drug-seeking appointment, because that's what it sounds like it was. And so I just wonder if there's certain things that we can kind of be on the lookout when we're in patient encounters like that, and there's no objective findings. Is there something that we could notice?
Yeah, I'd say that for him, I'd say it was mainly just him not acting like how you'd expect someone in pain to be. In that case, I'd say the biggest thing that I noticed wasn't really the way they were acting in mannerisms as much as just that most people, when they're in pain, I guess it's more just when people are in pain, they act in certain ways, and so it's more just it's not the personality that I look out for, but it's just do they have a higher pulse rate and all those other things that people in pain have. So.
Okay, let's move on because we're running out of time a little bit. So let's move on to nicotine addiction. So who was able to see a patient with nicotine problems? Okay.
Excuse me. I saw a 14-year-old girl, and she smoked half a pack of cigarettes a day. Smoked all of the cigarettes at school. A lot of her friends smoked, and her parents didn't know that she was smoking. And she agreed to cut back, but we were a little worried that she would actually follow through on that. She didn't seem, we weren't quite convinced that she would.
Wow, 14 years old. What grade is that? That's like 9th grade. It's high school. Okay, thoughts about that? That's a challenge. So you were concerned that she was not going to follow up with stopping her smoking. And so how did you even approach that with her? Were the parents there? Was she alone or?
So she did come in with her parents, but then as per the adolescent interview, we took her aside, and this is when we found out about that. It was when she was by herself and we were talking to her. And, we've talked about the stages of change with smoking cessation, and she really seemed to be in like a pre-contemplative, potentially contemplative stage. She didn't seem very sincere, I think we were worried because she does smoke all at school, and it's kind of a peer pressure thing. And so we just tried to talk to her about, more immediate impacts. So, because I guess at the age of 14, like telling her 50 years from now you might get lung cancer is probably not as effective as we tried to tell her that, your breath's going to smell bad and your teeth can turn yellow.
And so were you going to see her back sooner than you normally would to sort of see
Yeah,
if she
to try to maybe push her ahead one more stage of change. And
Thoughts?
With something like that, I mean, how did you handle the interaction with the parents from that? I mean, did you tell the mom and dad or what?
So we actually didn't this time because she requested that, we keep it amongst ourselves. And it was, there are only a few things that you actually have to report. And, we wanted to keep it confidential so that hopefully she would continue to trust the team of physicians and come back to us.
Did you encourage her to talk with her parents about it?
Yes.
Interesting. Okay, who else has a case?
So, how did you end up, or how did she respond to, your counseling and you pushing her to talk to her parents and all?
Yeah, I mean, as I'd said, she was not too responsive and didn't seem very sincere about cutting back at the time. But, we just tried our best. Whenever you have adolescent kids, it's really hard to convince them that the things that they're doing, that their friends do, that's cool, and what they think is cool is not good for them. So, we tried, but she was just a little unresponsive. But that's why we want to have her back and try to continue to talk to her about it.
Okay, who else has a nicotine case?
So we saw a 60-year-old veteran who had, I guess turned out to be a 70-year pack history of smoking. He had smoked 2 packs a day for about 35 years. And he was actually really interested in stopping to smoke. So we prescribed nicotine patches and then set him up at the Veterans Hospital with a support group. So it's other people interested in quitting smoking, and it's actually led by a social worker. So we're kind of hoping between the combination of the support group and the nicotine patches that it'll work for him.
In a motivated patient, which is
Yeah.
very, you're right, that's the first thing is having a patient who's motivated. And so the VA system has services for smoking cessation. So you were using a combination of sort of support group and patches.
Yeah, hoping that both would work. And it was interesting to see a patient that was motivated because a lot of times we'll see smokers and they won't necessarily have an interest in quitting. So for him to sort of approach us with that interest, that was a welcome and new change. So.
And just curious, what was motivating him? What was the thing that motivated him? Was it his health? Was it his family?
He didn't really say. I think he was just at the point where it's like, this is something that I want to do. He had recently retired, so I think he was just ready to relive a new aspect of his life. So.
Okay. Okay.
I've heard that smokers, when they try and quit for the first time, they tend to kind of relapse and stuff. So was that something that you talked to him about?
Yeah, we certainly counseled him about the difficulties and the fact that there would probably be some give and take to it, and that it shouldn't be considered a failure if he relapses, that it's just a relapse and it's a learning opportunity. And then we also tried to schedule in advance a couple of follow-up appointments so he would know he could come back and check in with us, and we could talk about the medication and the nicotine patches, how that's helping, and then the support group. And we're hoping, I think this support group especially will be helpful for that, but we're definitely trying to check in with him too.
Excellent. So our time is running out. So did you have a case, Al? So why don't we, we're sort of going to end it here. So next session that we do, we'll have you present sort of the case that you impanel first. But I think I noticed that Braxton didn't have a case for either of the impaneled conditions.
Yeah, I don't know. I'm at a general practice for my preceptorship, but I see mostly peds, so you don't see a lot of back pain or smoking cessation, hopefully, in peds.
So then could you share sort of maybe with the group what your take home was from the different cases that your classmates have seen?
Yeah, I think the key thing I was taking away is that although what you see in the clinic it's not as clear cut as those classic examples we maybe see in class, there are principles of what we learn from those classic examples and how to deal with them that we can kind of tailor to each specific situation. So, for example, like, you don't typically do a lot of imaging with back pain, but then Mike talked about how because of workman's comp, they needed to really prove that that was the issue. So there was a lot of imaging used. And so I think just kind of like tailoring your approach a little bit based on the individual scenarios is interesting. But then on the flip side, he talked about the treatment was still the same treatment that that patient would have got whether or not there was imaging done. So I think that on one hand, you got to kind of realize that each case is something special and individual, but on the flip side, you're learning the classic case for a reason. Does that make sense?
Yeah. And so, when you look at evidence-based medicine, evidence-based medicine is for the key cases that you see, and then sometimes you have to deviate from that because of the particular problem with the case that you have in front of you, and it's just important in your medical documentation to document why you've deviated from the evidence-based clinical practice guidelines for the particular condition that you have.